Hi, I'm Dr. Ayesha Butt. Welcome back to my YouTube channel. At TUSA Champions, our goal is to educate our audience about the eyes, systemic health, diet, exercise, and how it all connects to make sure that you're getting the best possible vision and we're reducing or limiting our risk of vision loss and blindness. While we're trying to do that, our goal is to bring some of the local specialists in our area to come and educate you directly. Their knowledge, their experience, and their expertise are invaluable. So to start off our interview series, today we have someone very special in our Champions community. He's a board-certified fellowship-trained vitreo-retinal ophthalmologist. He's a native Houstonian, born and raised in the Cypress and Tomball area. He attended the University of Texas at Austin, where he received highest honors and went on to complete medical school at University of Texas Medical Branch, where he was awarded membership in the prestigious Alpha Omega Alpha Society. He subsequently completed ophthalmology residency as chief resident at the Medical College of Wisconsin and completed his vitreoretinal surgery fellowship at the #1 hospital in the country, Mayo Clinic in Rochester, Minnesota. He has published papers, given lectures, and written book chapters in many ophthalmology journals and textbooks. So without further delay, let's meet Dr. Murtaza Mandviwala.
Thank you, Dr. Butt. It's a pleasure to be here.
How are you doing today?
I'm doing well. How are you?
I'm good. Thank you so much. I always ask this question from my specialist. What made you think about eye and, of course, the most delicate part of the eye, retina?
Yeah, so it's a funny story because when I was actually in medical school, I wanted to be a cardiologist when I was growing up. And just by chance, I walked into an ophthalmology operating room and I saw the eye, and it was the most beautiful organ I had ever seen in my life. And since that day, I've been hooked.
Very nice, very nice. And it's surprising, you don't need any glasses or contact lenses. So did any of your family members had retina issues, or anyone had any eye disorders that you got interested?
Fortunately, not so much. I have been blessed with my mom's eyes. My dad is actually pretty nearsighted, so I was lucky.
All right, well, nearsighted patients are very high risk for retinal detachments and tears. Of course, retina doctors become their best friends. So thank you so much for joining us today. We wanted to bring this informative sessions for our patients so they can understand, the nitty-gritty details about it. The most important point that we want to discuss is when patients think about eye doctors, especially retina surgeons, they get a little bit anxious emotionally, they get a little bit freaked out. Of course, we'll talk about the injections and the lasers and surgery, but how do you connect with them at that level where they feel comfortable and confident moving forward with the surgery or injections?
Right. And that's a great question. And I usually go to a patient and tell them that this is a common problem, unfortunately, in this day and age. And because of how common it is, we encounter it very, very frequently. And unfortunately, for better or worse, we get very competent in what we do as a retina surgeon and retina specialist. So I've been lucky to be trained very well, and I've had a lot of good experiences that allow me to treat the patient. And because of this, patients tend to be okay afterwards.
That's great. It's not very easy to have professionals speak patients' language, right? We get so comfortable in our own language that sometimes we forget to use the words that they actually understand. And that's the goal of today's video, to get that information in a plain, simple English. So today I wanted to cover the most important topic, of course, November being the diabetic month. We wanted to cover one of the most important things that you see and most common ones. So diabetic retinopathy affects an estimated 103 million people globally and is a leading cause of blindness in working age adults. Can you explain what diabetic retinopathy is and how diabetes impacts the retina over time?
Yeah. So just to take a step back, diabetes, it means that your blood sugar is elevated in the bloodstream. And just like how you have blood vessels everywhere else in the body, you have blood vessels in your eyes and in your retina specifically. And what happens is that over time, it's a slow process. The blood sugar damages these blood vessels. And in your eyeball, they also get damaged. And they can tend to leak. They can break open and bleed. They can start growing where they're not supposed to grow. And you can develop retinal detachments, diabetic macular edema, glaucoma, all from these consequences of these blood vessels growing and bleeding open from the diabetes. So these are the different ways that the eyeball is affected from diabetic retinopathy.
Very interesting. With nearly 35% of diabetic adults in the US affected by some form of retinopathy, could you break down the different stages of the disease and explain how the progression impacts vision? Like how quickly can you tell that, oh, I'm losing my vision?
Right. So there are really two big stages of diabetic retinopathy. One stage is non-proliferative diabetic retinopathy. The other stage is proliferative diabetic retinopathy. And the presence or absence of new blood vessels determines which stage you're at.
Right.
Proliferative being much worse than non-proliferative diabetic retinopathy. And what happens is, as I was explaining earlier, you have blood vessels, and those blood vessels become damaged as the diabetes progresses. And this leads to a lack of blood flow. So you get ischemia in the fancy medical term, where you don't have enough blood going to your eyeball. And when that happens, your retina actually starts waving a white flag saying, please help me. I need more blood. And the body reacts and it gives it more blood. But unfortunately, these new blood vessels are abnormal. They're fragile. They break. And this is what happened in proliferative diabetic retinopathy, where you have these new blood vessels forming. They're abnormal. They break. They cause retinal detachments. They grow over the drainage system, kind of like how hair grows over a drainage system, or how hair in a shower area can clog up the shower drain. And
it doesn't work as efficiently.
Exactly.
Is it similar to like spider veins on your legs or something where you can see these blood vessels?
Yeah. So you can definitely see these blood vessels inside of the eye. And we as eye specialists can see this whenever we take a look inside. And the dangerous part about this is that sometimes patients don't notice that they're having these vision changes. And just to take a step back again, non-proliferative diabetic retinopathy is when you don't have these new blood vessels, but it's still something that needs to be monitored because you can still have vision effects from that.
You can't just sleep on it that, oh, I have the non-proliferative, I don't have new blood vessels forming, let me just wait until it gets
Exactly
worse.
Right. Exactly
Absolutely. Right. So it is estimated that 40 to 45% of people with diabetes in the US don't even realize that they have diabetic retinopathy. Like I said, they can't just wait till it gets worse. What are some of the early signs people should look out for?
Yeah. So I think the first sign is that if you're diagnosed with diabetes, if you have a blood sugar that's elevated, if you went to a primary care doctor and they said that your blood level shows that you have diabetes, you need to be checked for diabetic retinopathy. And that's the easiest way to kind of just go in for an eye exam. And
don't wait for anything.
Exactly.
Just
don't wait for any visual symptoms at all. And that's the best way, okay? But patients who have fluctuating blood sugars can actually notice fluctuations in their vision because your lens actually swells whenever your blood sugar is elevated. And you might notice one day that, my vision up close is much better than it was before yesterday. And that's something that you really need to get checked out for because that can mean that your blood sugar is fluctuating a lot.
Right.
Central vision blurriness is also an important, if you're starting to notice just any type of central vision blurriness that doesn't improve. And if you're noticing peripheral vision defects, that's also extremely important to be checked out. And floaters is another important sign. So if you start noticing a lot of black spider webs type of scenario, like where you're seeing a sandbox inside of your eye, that's something to be checked out for as well, because that means that you could have bleeding in your eye.
And that's important for our listeners, that if your vision is changing, I had a couple of patients where like, I don't need glasses anymore to read. And I'm like, you don't need glasses anymore to read. That means there's something wrong. You know, it's not a good thing. So, and then, a couple of patients, they come get frustrated that, these glasses don't work anymore. And we tell them these are changes that we know are happening because of diabetes and your lens is changing. So a chemical is making it more, swollen or thinner. So, that being said, how important do you think regular eye exams are in detecting diabetic retinopathy, and how often should diabetic patients be screened, especially considering that diabetic eye disease is one of the leading causes of blindness?
Absolutely. So as I alluded to earlier, general eye exams are extremely important for diabetic patients because a lot of times these new blood vessels that you see do not affect your vision. And that's the severe stage of diabetic retinopathy. So if we're catching it at a severe stage, imagine if you were to go on a normal daily or a normal yearly basis, at least minimum on a yearly basis, patients should be checked out. you might notice those signs much earlier. And a lot of those earlier signs are the blood vessels kind of opening up and leaking a little bit, or a little bit of bleeding. And all of that can be noticed at the first initial visit, for a screening visit for diabetic retinopathy. As the disease progresses, patients may require more visits more frequently. And I have patients that come and see me every month for diabetic retinopathy because they, as we might get to earlier.
Is it both for non-proliferative and or it just depends how severe that stage is?
It's for both, because a lot of patients with non-proliferative diabetic retinopathy have leakage inside of their eye. And those patients don't see well because of that leakage, and they require injections. And some of these patients require injections monthly to get that macular edema, the fancy medical term for that leakage, to come down.
Sure. All right, no, that's great. So you would recommend everyone should get an eye exam every year. However, depending on the health of the eye and bleeding and leakage and how advanced it is, it could be every month. So
exactly,
don't wait till, it's really leaking. So with diabetes being the primary cause of over 4.2 million cases of blindness worldwide, how does diabetic retinopathy affect a person's daily life and ability to perform routine tasks like driving, reading a book?
And that goes back to what stage the diabetic retinopathy it's at. I have patients who are 30 years old and they were highly, highly functioning, working in a job, taking care of their families. And all of a sudden, they noticed that both of their eyes had bleeding episodes and they are completely debilitated. In that scenario, that's heartbreaking and it's distressing for me and the patient, because I want the patient to go back to being able to work and being a normal human being. So a lot of times the vision can change.
Let's jump to treatment options. So considering the serious nature of this disease and the fact that it's responsible for 12,000 to 24,000 new cases of blindness in the US each year, could you discuss the available treatment options and how effective they are at preserving vision in the US?
Yeah. So there are really 3 different treatment modalities that we go through. The first one is injections. Okay. And that happens in clinic. I know a lot of people get squirmy whenever they think about injection in their eye. But most often they're not as bad as what they sound like.
You numb it first.
Exactly right. We numb it first. And for that, we do that for macular edema, diabetic macular edema. And that's whenever you have leakage in the most central part of your vision. Sure. Okay. And this molecule that we inject inside of the eye decreases that amount of fluid. Okay. We also inject in the eyes whenever patients have those new blood vessels forming, or if they have bleeding inside of the eye, because again, this medicine that we inject decreases that amount of new blood vessel forming inside of their eye. So that's number 1. Number 2.
Could you give us some of the names? For some of our educated viewers, like what are some, and what is in that? Like you said, is it to prevent the blood vessels from forming or swelling, or it's not a steroid, right?
No, so it can be a steroid, but the most often injection medicine that we give is an anti-VEGF molecule, and there are many different types, and many patients may even know about them. Where there's bevacizumab, aflibercept, faricimab is a newer one that just came out recently. Ranibizumab is another one. These are all antibodies that actually neutralize the VEGF molecule, which was that white flag signal that I was talking with you about earlier that causes the new blood vessels forming. So the whole goal of the injections is to decrease that white flag signal so that blood vessels leak less, and that if there are new blood vessels, they disintegrate.
Right. Most of the time when we say, all right, let's get injection for pain or something, then patients assume that it's steroids. So that's great. I have another question regarding that. So any new updates coming up? Anything new that, clinical studies, trials, what's new?
Right. So injections, we're always trying to figure out stronger medicines to inject into the eye that don't have any side effects or have minimal side effects. And nowadays, what I was talking with you about earlier, sometimes I have to inject patients every month. And that's difficult for patients to come to because that's a burden on not just themselves, but on their families who have to bring them to clinic. Exactly right. So we're constantly coming up with new medicines that are longer acting so that they don't need injections every month. They may need injections every 3 or 4 months. And recently, there have been new advancements regarding this, and there have been very good outcomes. from these medicines.
Anything that you would want to add, especially in terms of diabetes in general, diabetic retinopathy, or, if our viewers have loved ones who are going through this, how to connect them at a level? What is the prognosis? Like how, when they finish the treatment, is there a light at the end of the tunnel?
Right. Good question again. And the most important factor, again, is catching it early on all of this.
Right.
As the disease progresses, your visual outcomes become worse. So if you catch non-proliferative diabetic retinopathy at a moderate stage, and we treat it and we're monitoring it, you have a much better likelihood of retaining very good vision. Whereas if we're seeing someone with a proliferative diabetic retinopathy who already has new blood vessels forming on top of their macula and causing a retinal detachment, of course, we can go in there and make it better. But there's always permanent damage that's left from that proliferative disease.
The clock is ticking.
Exactly right.
You can't wait for it to get worse, as we like to do.
Exactly right. It's not something that you can just put under the rug and, we can just do it next month or the following year or something like that. If you have disease, you need to have that treated to maintain your vision.
So what would you recommend, can there be early detection and treatment? Are there specific lifestyle changes that can help reduce the risk of developing diabetes and diabetic retinopathy as a result of diabetes?
Absolutely. And this all comes down to lifestyle is made up of two things. It's diet and exercise are the two main factors.
Right.
And specifically with diet, it's very hard for anyone to change their diet. And it's easy for us to say this, being on this side of the examination table or examination chair. But eating a Mediterranean diet specifically helps a lot with this. So a lot of fish oil, a lot of fish like salmon, a lot of green vegetables that are green leafy vegetables. All of this helps keep the diabetes level down. Taking your medicines also helps a lot with keeping the diabetes under control. Exercise helps with your insulin and how well your own insulin reacts in the body to keeping the blood sugar down. And losing weight can also help with how well your insulin works. Right. So all of these factors play a role in not only helping your body, but helping your eyeball retain its vision and decrease the amount of diabetic retinopathy that it has.
No, I'm so glad that you touched the most important point here, that, healthy diet, keeping your food intake proper, taking your medications in time is important. And that's where, we know the CDC estimates that 90% of the vision loss from diabetes can be prevented.
Yeah.
So, so with the global prevalence of diabetes and diabetic retinopathy expected to rise dramatically, are there any upcoming advancements or new treatments that could change the landscape of diabetic retinopathy care? I think you answered part of that question earlier with the new studies. Is laser part of it, or any surgeries? Can we transplant the whole eyeball?
Not yet for the transplanting the whole eyeball.
Yes.
But specifically, laser is it's a cornerstone of diabetic retinopathy treatment. And it's been known for many, many, many years. It's one of the older forms of treatment, but it works very, very well still. And how laser works is, again, it decreases that VEGF signal inside of the eye, or that white flag signal. And we can use it, and we actually laser the peripheral retina where it's ischemia and it's not functioning already, to decrease the amount of new blood vessels forming. So that's very important in diabetic retinopathy. And a lot of patients can have laser treatment for this, and it's solely preventative from that regard. There are lasers that you can do inside of the macula as well to leaking blood vessels, and that's also an important cornerstone of improving vision. Surgery is also an important way to treat diabetic retinopathy, and we reserve surgery for the most severe conditions, severe stages of diabetic retinopathy. Whenever you have a tractional retinal detachment, which is the fancy term for those vessels pulling up on the retina and causing a retinal detachment, or if you have bleeding in your eye and you can't see from that eyeball, we need to surgically go inside and remove that blood and clean out the eye and peel all of those new blood vessels. And those are still very good treatment options for improving your vision going forward.
Where does that fit with the anti-VEGF injections, and how does laser treatments affect the peripheral vision? Like they can still see, right?
Yes. So the peripheral vision, there is a side effect where sometimes you can have a little bit of constriction from the peripheral vision. But that's a small price to pay for maintaining your vision for the rest of your life. And I tell patients this because sometimes patients feel like, I'm going to lose my peripheral vision. Is it really worth it? And I say, absolutely worth it, because if this doesn't happen, you could lose your central vision, possibly permanently in that case. So that's very important.
We always tell patients, be careful with lasers. And when we say we use laser to save your vision, it kind of it kind of sounds funny.
Right.
But, just again, to reiterate the fact that we're burning part of the retina, decreasing the overall oxygen demand to prevent the central, more expensive part of the retina, right? To keep that healthy, to prevent it from progressing.
Exactly right.
Thank you so much. I think our audience learned a lot from it. If you guys have any questions, feel free to ask those questions. We will love to have him back so we can answer more questions. We have detailed videos about diabetes and diabetic retinopathy, and we would love to contribute more. Thank you so much for joining us today.
Thank you so much, Dr. Butt.
Stay tuned. We have another video focusing on macular degeneration. Again, the horrible side of the story, and it is the leading cause of blindness in the world. So stay tuned for that.